It's definitely a real source of suffering for our patients who, for whom continued fertility was a major priority. And sometimes I can't fix it.
CancerNetwork spoke with Dr. Kathleen N from the Stephenson Cancer Center, part of the University of Oklahoma Health Sciences, about identifying and treating low-grade serous ovarian cancer. Currently, primary cytoreduction, followed by paclitaxel and carboplatin, is one of the main standards of care. Moore highlighted the Phase 3 NRG GYO19 trial, which is currently evaluating letrozole with or without carboplatin for stage 2 to 4, primarily resected low-grade serous ovarian cancer, which she believes the results will be impactful to the standard of care. She concluded by discussing fertility preservation and taking the time to speak with her patients to determine what they would want prior to going into surgery or receiving different types of therapy. Overall, there's a lot of excitement on the horizon for this space, and she hopes her colleagues continue to focus on designing trials and interventions with low-grade serous ovarian cancer as its own molecularly driven tumor.
Just to start off, can you give a brief background on low-grade serous ovarian cancer and how you distinguish it from other types of ovarian cancer?
Sure. Low-grade serous ovarian cancer is a rare subtype of epithelial ovarian cancer. So it is a part of the classification of epithelial ovarian cancer, which is predominated by high-grade serous ovarian cancer, and then endometrioid grade 1, 2, and 3, clear cell mucinous, and low-grade serous ovarian cancer. And then there's others, transitional cell, et cetera. So it is a subset of epithelial ovarian cancer, but just as those other types of epithelial ovarian cancer I just discussed, we have an increasing understanding that they're just vastly different tumors molecularly from one another, and are starting as best we can to really try and target in molecular ways or in targeted ways our therapies. BRCA in high-grade serous is the best example. We're really working on clear cell, and I think low-grade is another place where we're really trying to pull those out and develop therapies specifically for them, because they really are different. They are different in a number of ways. Epidemiologically, they tend to happen in a younger age range than high-grade serous, although it's important to note that you can see low-grade serous ovarian cancer in any age patient, but the median age is about a decade earlier than we see with high-grade serous ovarian cancer, even more so. You will see the precursor lesions tend to be quite a bit different. High-grade serous, we focus on the stick lesions, TP53, alterations in the fallopian tubes. In low-grade serous ovarian cancers, the precursor lesion that we believe is there is really these tumors that we used to call borderline tumors or low malignant potential. Although I will say that not all low-grade serous have at least an identified precursor lesion, but certainly we have evidence that these low malignant potential or borderline tumors, serous tumors, can progress to low-grade serous ovarian cancer. They tend to not have TP53 alterations. Maybe you can sometimes see a mixed picture, but that's one of the dichotomizations that you can see between high-grade and low-grade. And they tend to be characterized more by MAP kinase alterations when you look at the molecular profile. So you'll see in almost 40% RAS alterations, predominantly KRAS, but you can see HRAS and NRAS, but it's predominantly KRAS. You can see BRAF. BRAF V600E tends to be mutually exclusive with KRAS, but type 3 BRAF, which is pretty uncommon, but you can see both. And so whether or not we target those differently is something we're thinking about. And then we don't even always test for it because we sort of believe it's there in a ubiquitous fashion. But these tumors are really much more endocrine driven than high-grade serous, where in both scenario, you'll find estrogen receptors. You find those, if you look in high-grade serous, you'll find estrogen receptors, but you don't see us using endocrine therapies a lot there because it's not really driving what's bad about those tumors. But in low-grade serous ovarian cancer, blocking endocrine receptors is a major part of our therapeutic armamentarium. because it can be estrogen, predominantly estrogen receptors, and estrogen signaling is one of the kind of major oncogenic drivers for these diseases. So molecularly, they're just very different tumors. And then even clinically, given, I think you can't oversimplify things. I've certainly seen patients with low-grade serous ovarian cancer with ascites and very rapidly growing disease. That happens. More commonly, though, these tumors, I don't like the term indolent because it makes it sound unimportant, but they tend to be slower growing. They tend to be very invasive, whereas high-grade serous sometimes just coats surfaces and you can peel things off. Low-grade serous, like you'll see invade into muscle and you'll see them invade into skin. And the surgeries to remove them can sometimes just be really difficult and require kind of high volume surgeons and a lot of radical procedures to render a patient no gross residual. And so you'll see I think increasingly, patients not getting kind of frontline surgery because it is, so difficult. And we can come back and talk about that. So you'll see patients either with recurrent disease or disease that could never be resected. Their imaging is different. They have calcifications on the CT scans. Assessing response, especially by RECIST, can be quite difficult, in these calcified lesions. Not that it's easy in high-grade serous either, but, they're just, I think just in so many ways, just very different tumors from high-grade serous. And yet, until the very recent past, we have just tried to apply the same high-grade serous paradigm, to low-grade serous without a lot of real benefit. And I think we're seeing that start to change.
Great, thank you. I think you did a really great job kind of differentiating between high grade and low grade and all of that in between. So kind of going off that answer in the last part of that, what are some of the current first-line treatment options for LGSOC?
First-line treatment is, I would say, evolving. The standard of care, ideally, is very similar to high-grade serous. It's primary cytoreduction, and I'll come back to that point, followed by paclitaxel and carboplatin. There is retrospective data, although at a single large site, experienced site, MD Anderson, this is Dr. Gershenson's work, that looked at a population of patients who were primary cytoreduced and got chemo with or without maintenance letrozole, and the maintenance letrozole group retrospectively looked much better in terms of their progression-free and overall survival. And so even though it doesn't have a confirmed phase 3 study, that got NCCN listed, and I think many would consider that to be one of the leading options for standard of care in that setting. Some people will use bevacizumab, and bevacizumab is an active agent in low-grade serous as well. That's always good to remind. But I do see, and I believe most are using chemo and letrozole. There were very small, again, retrospective studies in, again, patients who'd undergone primary cytoreduction with near or complete resections who did not get chemo at all and went directly on to letrozole, which is, of course, an aromatase inhibitor. And those small studies without control arms did demonstrate kind of strong signal that could be an appropriate intervention. So that also is listed as an option in the NCCN, although I'm going to show my bias a little bit. I don't think that is a standard of care, personally. I think others might disagree with me, but I don't think we have enough data yet to really prove that. So that brings us to one of the more important clinical trials that's just about completed accrual, which is amazing. That's through the National Cancer Institute. It's called NRG-GYO19. And it's led by Dr. Amanda Nichols-Bader, who actually published the first reports of letrozole alone. So it randomizes patients with stage 2 through 4, primarily resected low-grade serous ovarian cancer, to paclitaxel carboplatin followed by letrozole versus letrozole. And so that study has accrued, and this is a rare tumor in a frontline study, so it's accrued ahead of schedule through the NCI, just to, again, and maybe politically not popular, but I'm going to say it anyway, the NCI really is driving change in treatment paradigms in a lot of areas, but here in a rare tumor. Like this study could never have been done, outside the NCI. And so, yeah, we've done it ahead of schedule. So it's a really big accomplishment. Now, I think the endpoints, because it's low grade, take probably several years till we know the answer. It's a non-inferiority study. So I think it's an incredibly important study, and we'll kind of have to wait and see what that looks like. But that's, even though we're almost done with accrual, it's not going to read out for a number of years. So I think that's the current standard of care. Challenges in the front line, I alluded to this. If you look at kind of registry information, the percentage of patients who are being dispositioned to neoadjuvant chemotherapy in this setting is increasing. And that's a little bit alarming for a number of reasons. The first is that this diagnosis, and I didn't mention this earlier, so I'm going to mention it now. The diagnosis is difficult to make, especially off of a little nibbin of FNA or some little laparoscopic biopsy. And the diagnosis around ovarian cancer is so critically important. So we can send molecular testing, but also so we know what we're testing, so we can make appropriate kind of surgical disposition. So really getting a good tissue diagnosis, if you are potentially considering neoadjuvant, is really critical here. And pathologists, will tell you this can be a hard diagnosis to make. And sometimes they have to do the molecular profiling to really kind of make the diagnosis. So that's one thing I think that's really important, is that you can't make this diagnosis and disposition a patient based on cytology or an FNA. Like, you really have to know what you're treating. The second thing about neoadjuvant that's troubling is that there is data, again, from MD Anderson, and I believe there's a paper from MD Anderson and a paper from Dr. Beryl Manning-Geist, who just finished her fellowship at Memorial, that are very consistent, looking at rates of response in the neoadjuvant setting to chemo, to paclitaxel and carboplatin, which, again, in a high-grade serous population, you expect pretty robust responses and the ability to get someone to a safer surgery. But the response rates with chemo in low grade are in the 20% range. You're not seeing this like massive melting of disease to make things easier. And I do think we don't have any data on this. So this is a data-free zone. But many of us think that in the case of a low grade, while your goal in high grade is always, you don't operate if you can't get someone to no gross residual. And of course, that should be your goal in low grade. There are some of us that wonder if low grade is a different metric. Like, maybe I get as much out as I can, because if you don't get that patient to surgery, because you can't bank on the chemo working really well, right? So a lot of times you'll disposition to neoadjuvant and they never get surgery, and they're just walking around with this ever slowly increasing calcifying bunch of tumors, that can lead to more suffering. And so if you could get 80% out safely, should we be doing that? I think is something that I wish I could see studied, but I think it's worth considering. And that's why making the diagnosis is so important. But there are patients for whom you just can't get it out. In the best of hands, it's so invasive, it's covering everything. What do you do? Here we do have some more clinical trials that are small, but I think give us some hope for the future. Neither have been published yet. The first is by Dr. Lauren Cobb and her colleagues at MD Anderson, who did neoadjuvant abemaciclib, so a CDK4/6 inhibitor plus fulvestrant, so a SERD. And they did neoadjuvant not in our, again, traditional high-grade serous way to 3 cycles and then see if you can resect. They just did it until they got enough response they could go to the OR, which was sometimes many months down the line, but they still were able to get a very high percentage of this small cohort. When she presented it, I think it was just 14 patients, and I'm looking forward to, I've heard that we'll see the publication soon. So I'm actually really looking forward to that publication. because what at least they showed in presentation was that they did get patients to OR. And I think that's important here. And the response rates were much higher than with chemo. So there may be a paradigm shift there. Currently, it just launched at Memorial Sloan Kettering and Emory. Again, this is Dr. Rachel Grisham and Beryl Manning Geist. And we're hoping to open it as well, called the Chameleon Study. And we're going to talk about this combination of medicines in a moment, but this is avutometinib, which is the RAF/MEK clamp, defactinib, the FAK inhibitor, plus letrozole as a neoadjuvant, like really get the tumors to shrink, get them to surgery, and then de-escalate to the endocrine therapy as an investigator-initiated single-arm study. I love these two studies. I love them. And they're incredibly patient-centered in that they're really trying to see if we can get more patients who otherwise would probably never get debulked to surgery. And we'll see, but I do believe that I actually believe it will improve survival. I definitely think it will improve, as long as we don't have surgical complications, improve quality of life, to have far less, again, of these calcifying masses in your abdomen moving forward. So I think the front line is going to change with these one big phase 3 and these two neoadjuvant studies. I think we're going to see some paradigm shifts coming up, and it's not going to be a paclitaxel carboplatin world anymore, is my prediction. But for now, it is.
No, this should be exciting. I know SGO is coming up in a month or so maybe we'll see some new data there. I know you just went through a couple of different key clinical trials. I don't know if you wanted to expand on that, if there's any others you wanted to touch upon, and maybe how these results might disrupt current standard therapies.
Well, I think that we've seen in the recurrent setting several clinical trials of CDK4/6 and endocrine therapy. We saw Dr. Brian Slomovitz present ribociclib and letrozole at SGO a couple years ago. Response rate was around 24%. Maybe I may have that a little bit off, but we have to remember, with chemotherapy, our response rates are less than 10%. Our most active drug is a MEK inhibitor alone with a 17% response rate. That's your most effective therapy in an all-comer. We'll talk about a little bit more in a second that. So above 20% with RECIST responses, I think is noteworthy, especially when that's I would say a fairly well-tolerated regimen. There are side effects with CDK4/6 and endocrine that we have to acknowledge. They do impact quality of life. But our breast cancer colleagues have really, I think, paved the way for us to understand how to use these combinations safely and maintain quality of life and patient benefit. So I do think that that's something you see that, I think you'll see that on NCCN soon. And of course, that's already bumped up into these frontline neoadjuvant studies. My question is, maybe is that better maintenance in a high risk? Is that just something I use in a neoadjuvant? Is that something I use in someone that got debulked, but they have residual disease? Is letrozole, you don't always need to be adding, right? Maybe letrozole maintenance all I need. And patients do great if they're fully resected. So where that CDK4/6 best fits in the next generation of trials, I think is an active question. But right now in the recurrent setting, that is absolutely an option. It's off-label, though. I want to emphasize that. So we have to be cautious around not inducing financial toxicity for our patients. It is off-label, so I want to say that. But there is, I think, fairly strong data of efficacy. And whether or not there are differences between the CDK4/6s, certainly we believe that's true of breast cancer. I think we've seen some recent data on that. In low grade, was abemaciclib better than palbociclib, better than ribociclib, or the reverse? We don't have anything near that to say. I'm just grateful to get any of them because they're off label. So I would just say thank you. When I get a CDK4/6, I think we'll get to a point where we can maybe put them in efficacy order. But the same is true of the endocrine therapies. I don't know, I have this sort of bias that fulvestrant is better, but I don't know where I got that. I think it's just my own magical thinking. Is a SERD better than an aromatase inhibitor? Better than, well, it is better than tamoxifen. We've shown that. So of the CDK4/6s and endocrines, like how to order them, we're not quite there yet. So that's sort of one set of things in the recurrent setting. You've already seen it bump up. The second set of data in the recurrent setting is, of course, I mentioned the avutometinib, and defactinib, which is it's a RAF/MEK clamp and a FAK inhibitor. And that came from really, really lovely preclinical work, to be honest, that elucidated some of the mechanisms of resistance to MEK alone. It's sort of this feedback loop. So if you hit both with the clamp, you get rid of one of those feedback loops that leads to MEK inhibitor alone resistance. And then upregulation of FAK is another kind of escape route. And so they brought it together, and lo and behold, we have an optimized dose for the combination based on work by Dr. Susanna Banerjee and Dr. Rachel Grisham. That was presented at IGCS in 2024. And, the data is pretty compelling, especially in the RAS-altered low grade. In that population, your response rates were above 50%, like 50 to 60%. That's unheard of. We've never seen that. In the KRAS or RAS wild type, it was a little closer to what we see with MEK alone, but so you might say, well, we should just use it in RAS. We can't say that yet. And Rachel Grisham taught me this, and so I want to credit her, because I was like, well, maybe I'll use this for RAS and I'll use endocrine for not RAS. Like that was sort of how I was thinking. But the RAMP 301 study is ongoing. So that's open and accruing globally. So people should know about that. It's the avuto defactinib versus investigator's choice. Importantly, it has crossover, which I love. So if my patient gets investigator's choice, which makes me sad, I can use that, and I use it until they have actual progression. You can't, cheat and say they're progressing. They progress, but then they can cross over. And we haven't really seen any sense that it works less in later lines of therapy. So it's a really great study, and I want to put a plug in for this. Dr. Grisham is leading this internationally. But the importance of that trial, because you're like, why do I need that trial? It looks great. Just, do accelerated approval. I'm going to use it just in RAS. RAS is prognostic. So a RAS tumor versus a non-RAS tumor is going to have a different prognosis. So without having a control arm of RAS, mutated RAS wild type, getting investigator's choice, you really can't judge what 17% or whatever it ends up being in the RAS wild type looks like to you. It may look way better than what we see with standard of care. Like that may be 3 times better than what we see, because RAS is prognostic. So we really have to get this particular trial across the finish line so that we can really counsel patients as to the expectations of efficacy for their molecular subtype of low grade when they're getting this therapy. Ultimately, patients are going to get both an endocrine-based therapy and a avuto, which is which order are you going to use them in. And again, going to the chameleon study, maybe some patients are going to get it kind of upfront in the future. So I think that the CDK4/6 endocrine combinations and the novel MEK clamp defactinib combinations are really key.
All right, so I know you talked a little bit about recurrent LGSOC, but maybe can you just briefly discuss your approach to treatment management when you see a patient like this?
So these are always a challenge because our goal is to, of course, meet patients where they are in terms of meeting their goals, doing whatever we can to try and help those goals. But sometimes you just can't. and you have to have a conversation, because ultimately, as an oncologist, my goal is to really participate in a kind of shared goals, shared decision-making discussion with my patient, but always trying to prioritize survival and making sure that we're all on the same page with choices and their impact on survival. I think with low-grade tumors, sometimes they present in such a way that you can preserve one ovary, or you can preserve the uterus for a period of time, and have all the sorts of assisted reproductive technology help, either with donor eggs, goodness gracious, donor eggs, or banked if you had time to do that. But we have to just keep in mind, it kind of just depends on how advanced the case is, how involved the ovary is. Assisted reproductive technologies do sort of drive kind of hormone production. And if I have a hormonally driven tumor, could I make that worse? At least in breast cancer with hormone receptor positive breast cancer, we saw data relatively recently from Dr. Ann Partridge that pregnancy stopping therapy so they could have a pregnancy actually didn't impact their recurrence risk, which I thought was just this phenomenal piece of research that came out. And that kind of applies here a little bit, although those maybe were different stages of patients with breast cancer, but it's the same kind of idea. One of my colleagues says low-grade serous ovarian cancer is kind of the hormone receptor positive breast cancer of the pelvis. We borrow a lot of things from hormone receptor positive breast cancer and bring them to our patient population when appropriate. So it's really shared decision making. If you have time, that you can allow for egg retrieval, and then go to the OR, you can do that. As I mentioned, preserving a uterus, preserving an ovary, and then coming back and resecting, making sure you understand, or I understand, what my patient would want at the time of surgery. And sometimes you have to you hate to do this, but you'll do a staged procedure so you can have a conversation. I've definitely seen this where we've left an ovary for a few months and then they come back and they're like, just take it out. And that's not absolutely, you don't ever want to do repetitive surgeries, but sometimes that's what you have to do in a safe way to allow patients to really work through what they want in terms of maintaining their fertility. I think the biggest challenge, at least in my part of the world, is that I take care of a lot of patients who aren't incredibly wealthy. And so a lot of times these technologies that they would need to preserve fertility aren't covered. And so they desperately want to maintain their fertility, but they don't have, unfortunately, the financial means. And so then we're in that's like a whole nother layer to the conversation that just adds a layer of grief, for them. So it's definitely a real source of suffering for our patients who, for whom childbearing, continued fertility was a major priority. And sometimes I can't fix it for them. But I think it's just the conversation, referrals, letting them, even if you think they can't afford it, refer to infertility, let them have that discussion, let them ask all the questions and be informed and make their own decisions rather than you kind of making judgments for them, which sometimes I think unconsciously do. So those would be kind of my topics. And then, it's not just fertility, it's just also around these patients who are younger, premenopausal, and we surgically castrate them. And then we block their hormones. And so all of a sudden they're in acute menopause and their joints hurt because I've got them on letrozole and they're having hot flashes, and I'm not going to give them hormones back here because we're not quite comfortable with that yet. So that whole level of kind of psychological, it's physical suffering, but it leads to kind of emotional suffering too, just the loss of being a young estrogenated person. There's just a lot of layers that's true when you're taking care of people of all ages. There's just layers to what you lose to these diagnoses and how you help patients gain some control back and feel like it's just not all been swept away. But it's a challenge.
I think you did a really great job contextualizing that. Just kind of as we're coming up on time here, do you just want to briefly say like what you're looking forward towards in the future for this specific field?
Well, I'm just looking forward to the fact, I'm really happy with the fact that we've seen in recent years, there were 2 other big phase 3 studies for MEK inhibitors. So this isn't brand new that we're studying low grade, but it's relatively like this kind of latter 10 years of my career that we're really focused. Like we really understand that this is a different disease. We have been communicating with the regulatory authorities about why this is a different disease and the benchmarks for success, the study designs are different than they are for high-grade serous. You still want a clinically meaningful outcome. We're not looking for marginal improvements, but everything just looks different. And so that's been a process that I think has been very successful. So we have, I think, a lot of momentum moving forward, looking at this as an individual disease and thinking about it as its own molecularly driven tumor and really trying to design trials and interventions that focus on that rather than just like using the things we are comfortable with from high-grade serous. And there's just a lot of also, I think, scientific exploration around low grade. There's also a lot of research on outcomes based measures around quality of life and impact of the things that we do, which we've really not ever focused on before. We're always so focused on the drug, but not the impact. So I'm pretty excited just in general around the interest, the recognition that this is a different disease, and clear cell and mucinous, they're different. They deserve to be studied as individual diseases. They need to be understood. And we need to be designing trials that are kind of scientifically based in what that disease is. And we're seeing that now with RAMP 301, with Chameleon in the front line, with the work that Lauren Cobb did in the front line with abemaciclib and fulvestrant. Like those were, and are, Chameleon still unrolling, like thoughtfully developed studies for this disease, asking a specific question, and outcomes were designed with a complete understanding of this disease. And I'm really very excited about that because I think that's how we're going to really drive meaningful changes in how these patients are cared for until we can figure out a way to screen for it and just prevent it altogether, which is the penultimate goal. But I think I'm excited about the studies that are ongoing and just the kind of critical mass of people thinking about it. Feels bigger than we've had in the past, and that's gotta produce some great things, I think. So that's what I would say.